Welcome, everyone. We will be getting started very shortly. Welcome, everyone. Thank you for joining us. I am Chelsea Reeves, Community Engagement Coordinator with the Mayo Clinic in Jacksonville, Florida. Today, I have the privilege of serving as moderator for the June Cancer Town Hall on skin cancer. Should you have any questions throughout this town hall, please place them in the Q&A section and staff will field the questions following the event. Joining us today are two panelists, Dr. Colin Costello and Jen, our survivor speaker. I will share both of their bios first and then invite them to speak. Our first speaker is Dr. Colin Costello. Dr. Costello finishes his dermatology residency at Mayo Clinic this month. He will be starting on faculty here at Mayo Clinic this summer with a particular interest in high-risk skin care and skin cancer and melanoma. His research focuses on closing the inequities in melanoma with our minority populations. Our second speaker is Jen. Jen is a native Arizonan, spending nearly 40 years in the Valley and very much of her early years in the sun. Jen started using tanning beds at the age of 16 and was diagnosed with melanoma at the age of 28. She is a survivor of this deadly disease. Jen is diligent with her annual skin checks, and to ensure no reoccurrence of skin cancer, and has been cancer-free for almost 12 years. So now we invite Dr. Costello. Please share your presentation.
Perfect. Thank you, Chelsea, so much. Let me go ahead and share my screen. Perfect. And are you able to see the presentation?
Yes.
Perfect. And it's not in presenter mode?
Nope.
All right, excellent. Well, we'll go ahead and get started. So I have no conflicts of interest today, and all the photographs of Mayo Clinic patients have given their permission for these photographs to be used for educational purposes. We'll briefly touch on basal cell carcinoma and squamous cell carcinoma and spend the majority of time talking about melanoma, but these are the three most common types of skin cancer. So basal cell carcinoma comprises the most, and it's often locally invasive, but doesn't metastasize or doesn't move to other areas of the body and is treated with surgery. Squamous cell carcinoma, the second most common type of skin cancer, also often just locally invasive, but more rarely can metastasize and move to other areas of the body. It's also the most common skin cancer found in our transplant patients or immunosuppressed patients. Lastly, melanoma, although more rare than basal and squamous cell carcinoma, has increased morbidity and mortality related to it, and it arises from the pigment cells. Before moving into talking about melanoma, I just wanted to show you some clinical photographs of basal and squamous cell carcinoma, just to give you an idea what they look like. So here's a basal cell carcinoma on the sidewall of a nose, and you can see they're kind of these more pearly pink papules. This one has a little bit of some superficial ulcers on it. And here's a basal cell carcinoma hiding within the sideburn on an individual's face. And then also basal cell carcinomas, they can develop pigment within them. And you can see more on the left side of this basal cell, you can see some pigment starting to come through. And here on a skin of color patient, we can see the basal cell carcinoma is actually mostly black and brown. And sometimes these can be a little bit harder to distinguish from melanomas. And we'll get consults from our primary care providers to rule out melanoma, and ends up being a basal cell carcinoma. For squamous cell carcinoma, you can see they're a little bit more yellow. They're a little bit more crusted. These can be indurated and tender to the touch as well. And here's another photograph of another squamous cell carcinoma. So we'll go ahead and dive right into melanoma. And the first thing we'll talk about is the different incidents or how often melanomas occur. So within our white populations, you have about 45.8 melanomas per 100,000 patients. The second highest incidence of melanoma is with our Hispanic patients, about 6.8 per 100,000. And this specific paper lumped together Asian Americans, Native Americans, and Pacific Islanders, and that came in just under 6 per 100,000. In our African American patients, you can see about 1.3 per 100,000. So to give you some reference, there's about 6.7 times more melanomas in our white patients compared to our Hispanic patients, and just under 34 more times melanomas in our Black patients compared to our white patients. And certainly it wouldn't be a melanoma talk without talking about some of our racial and ethnic disparities between our different racial and ethnic groups. This is a manuscript that was looking at the overall survival within different groups. So if a number is closer to 1.0, that's surviving. And so the lower the number is on this chart, the worse survival is. And you can see that blue line is the highest, and those are our white Caucasian patients, while the red is our lowest line, and those are our African American patients, with our Native Americans, Pacific Islanders, and Hispanics also decreased with their melanoma survival compared to whites. And when you break it down more, so when you think about melanoma, there's different stages. So stage 1 and 2 melanomas are locally invasive cases, while stage 3 melanomas have spread to our lymph nodes, and stage 4 melanomas are distant diseases like the brain and the lungs. And you can see that in this one, we have white patients are red, and Black patients have the black ticks. And you can see particularly in stage 1 and stage 3 melanomas, our African American patients have significantly worse survival stage for stage. So next we'll go ahead and talk about what are the different drivers and risk factors for melanoma. So certainly one of the largest ones is ultraviolet light, and this can be from spending time outdoors, such as at the beach, as well as artificially with tanning beds. And certainly studies have shown that even one tanning bed experience significantly increases your risk of developing a melanoma. When you think about risk factors, you can have modifiable and non-modifiable risk factors. So non-modifiable risk factors on the right-hand side, these are more genetic and just things that we really can't modify. So this is our hair color, particularly red hair, skin color, so a lighter skin tone, more susceptible to melanoma, having a family history of melanoma, and having a light eye color as well. Now, modifiable risk factors on the left, these are things that we can do to decrease our risk of developing melanoma. So certainly limiting our sun exposure, and we'll talk soon about sun protective practices. Limiting the development of blistering sunburns can be particularly useful. Studies have shown that blistering sunburns developing in adolescence and during childhood definitely increase our risk of developing melanoma. High altitudes and in reflective climates such as snow and water, where you can have UV radiation reflecting off the water and snow right back up into your face, is another high UV burden site. And then lastly, we kind of talked about tanning beds already. So just a photograph to remember that freckles, red hair, light colored eyes definitely increases an individual's risk of developing melanoma. Another risk factor for melanoma is having multiple moles and also atypical moles. So you can see this individual on their back has quite a few different sizes and shapes of their moles, and this portends an increased risk of melanoma. So how do you protect yourself from the sun? And really, there's a multitude of different things to do. So avoiding the peak hours between 10 a.m. and 4 p.m. when the ultraviolet radiation is the highest. Wearing a wide brim hat will help protect your face and your scalp. Using sunscreen with at least 30 SPF, if not higher. Reapplying every 80 minutes if you're doing any water sports, or 2 hours if you're out and about but not really sweating. Using sunglasses that block ultraviolet radiation. We can develop skin cancers right along our eyelids as well, and sometimes those are really hard to apply sunscreen in the area. So if you're not using sunglasses, you're going to have increased UV exposure there. staying out of direct sunlight, so staying in the shade, particularly those peak hours, and using some protective clothing, particularly clothing that has UPF in it. UPF is the clothing equivalent to SPF. And there's multiple companies, both in person and online, that sell these type of clothing. When we think about sunscreen, there's two large differentials for sunscreen. So there's our physical or mineral-based sunscreens and then our chemical blockers. So one of the pros to the physical-based sunscreen is they are wide coverage or broad coverage. So they block UVA and UVB. These are their two different subtypes of ultraviolet radiation. And the protection works as soon as you apply the sunscreen, since it reflects the ultraviolet light. One of the cons is it can be more white and chalky in appearance and be more difficult to blend into the skin. For chemical-based sunscreen, they're often thinner and go on a little bit easier. They don't necessarily have any white sheen left behind. But certainly you have to use different ingredients, multiple different ingredients, in order to have that wide band of coverage for both UVA and UVB light. But with multiple different ingredients within it, they're able to have widespread coverage. The chemical-based sunscreens, how they work is they absorb the ultraviolet light instead of reflecting it like the mineral-based sunscreen. Next, we'll move into some of the ways to identify a melanoma. So one of the most common ways is the ABCDEs. So A stands for asymmetry. So on all these, the left-hand side will be photographs of a melanoma, while the right-hand side will be photographs of a mole. So asymmetry, you're looking for asymmetry of a lesion side to side. Often our moles are more symmetric. Borders is for irregular borders versus regular borders. So irregular borders is what we see in melanoma. You can see on the left-hand side, those are relatively irregular, while our moles on the right-hand side are pretty round and have regular borders. C stands for color. So melanomas often have multiple different colors and shades of brown within them. And you can see on the left-hand side, we have multiple light, dark shades of brown, while we have more relatively uniform color with the moles on the right. Diameter, often the diameter cited is 6 millimeters. This is about the size of a pencil eraser or an Apple pencil. So melanomas often are larger than 6 millimeters in size, while moles are often, but not exclusively, 6 millimeters in size or less. And then additionally, any spot that's evolving or changing over time is concerning and should be addressed to make sure it's not a concerning spot for melanoma. Outside of the ABCDEs, you can think of the ugly duckling rule. And what this is if you have a spot that looks a little bit weird and different from the rest of the spots on you, that's a good spot to have checked out. So you can see this individual, multiple moles on the back. The arrow is pointing to a melanoma that was later biopsied. And you can see that spot kind of stands out on their back compared to the surrounding areas. I wanted to touch on acral melanoma. So not all melanomas are ultraviolet light induced. Acral melanomas are melanomas that occur on the soles, in between the toes, under the fingernails, and more rarely on the fingernails, toenails, and on the palms of the hands. And so here's some photographs. Sorry, they look pretty advanced, but you can see a melanoma on the left-hand side underneath a toenail. In the middle here, we have a melanoma in between the toes. And on the right-hand side, we have a melanoma on the sole of the foot. And why acral melanoma is important to bring up and address is because there's a higher incidence or a higher proportion of melanomas in our Hispanic and African American patients will have acral melanomas, and so a little less UV induced melanomas and more of this subtype. And unfortunately, these are often we don't think of melanomas occurring on the soles underneath the toenails as often, so they're often not discovered until late, and because of that, they can have a worse prognosis. So just wanted to bring that to our attention here. Next, we'll talk about how to perform a cell skin examination. So this is something we recommend everyone do just to get in touch with their body and make sure there aren't any concerning spots that need to be addressed by a medical professional. So how do you perform a self-skin examination? Often you derobe in front of a mirror. And then when you face the mirror, you can really take a look at your face. You can run a comb through your scalp. You can take a look at your neck, your chest, look underneath your arms as well, and your upper extremities, your fingers and your hands. Next, you'll turn around and face away from the mirror. Then you can use a hand mirror to look at the back of your scalp, your back, your lower back, and then use the mirror to kind of look at your buttocks as well. Then you'll go ahead and sit down, and then you can look at your thighs, your shins, your feet, and then using a hand mirror, you can look at the back of your thighs, your calves, and the soles of your feet as well. So what do you do if you find something suspicious? Certainly take a photograph of it, make an appointment with your primary care physician or dermatologist. If you're able to send in photographs to your providers, that's another great way to get their attention, their input. It might be able to help expedite an appointment if they deem it a concerning looking lesion. And remember that catching a melanoma early will lead to lower stage and improved survival. So I wanted to lastly touch on who needs a regular skin cancer screening. The U.S. Preventative Task Force has not fully recommended that the general population without any additional risk factors in the United States requires regular skin examination. So, if you're low risk and you don't have any of the higher risk features we talked about, thinking at least doing a self-skin exam. And then if anything comes up, that's when you want to talk to your primary care provider or your dermatologist. Anyone who's moderate risk, you could think of this as red hair, light skin, lots of UV exposure over your life, or having a family history of melanoma. You should do your self-skin examination and then have either your primary care physician or your dermatologist do self-skin exams as well. For our more high-risk population, these are people with a personal history of melanoma or atypical moles. These are people that need to be screening themselves as well as having a dermatologist evaluate their skin. And then our more ultra high-risk patients, these are people with a personal history of melanomas, as well as people with a genetic predisposition. They should certainly be doing their self-skin exams and then also have a melanoma specialist looking over their skin. So lastly, in the last few minutes, I wanted to just briefly touch on some of the research we're doing. Specifically, I've been looking in trying to do more educational-based projects with our Latino Hispanic community. And right now we have a project, a pilot we're just finishing up, and then hopefully later this summer we'll be launching a larger project looking to use some of the similar education to what we talked about today to help bring more awareness to melanomas that occur within our Hispanic Latino community. As we might have recalled from the beginning, this community has the highest incidence of melanoma, or the highest rate of melanoma outside of our non-Hispanic white patients. Some of our early data from the trial has shown that we've been able to increase patients' melanoma knowledge by just under 17%. And they've had increase from just about 30% to 90% of participants rating their melanoma prevention and detection knowledge as good or excellent. And then from about a third to just over 3/4 of participants stating that they're extremely likely to use sunscreen after going through our educational product. And then going from about 60% to just under 90% of patients rated their confidence in checking their own skin for signs of skin cancer as fairly or extremely confident. Perfect. And I just wanted to go ahead and end here and thank you guys so much for the time.
Dr. Costello, thank you so much for great information and sharing your insight. We really appreciate you, sir.
Yeah,
Okay.
absolutely.
And again, if anyone has questions, please put those in the Q&A section and the staff will field those questions later. Next up, we'd like to invite Jen. Please be prepared now, Jen, to share your experience. Thank you so much.
Hi there, can you hear me?
Yes, ma'am.
Okay, great. After hearing Dr. Costello speak, there were significant check marks that I had been ticking off of my mental list of my history. And some of that is kind of why I'm here to talk to you today. So as Chelsea mentioned, I'm an Arizona native. I've spent nearly 40 years in Arizona. And in my childhood, I was on the swim team and spent a lot of time in the sun. Every weekend for the better part of about 8 years, I would spend every day, all day in the sun at swim meets. I refused to wear sunscreen, and I would come home sometimes with those blistering sunburns, and it was miserable. But fast forward to high school, I, against my better judgment, in preparation for the homecoming dance, went and joined a tanning salon at 16 and decided to get a base tan. And the first time I set foot into a tanning bed, I think I was in for about 10 minutes and I was torched. And I went into my workplace at the time, and it's where all the cool kids hung out. And the quarterback of the football team came up to me and he was calling me a lobster and everyone was laughing. And so my 16-year-old ego, you'd think, would have been bruised enough to make that a one and done experience, but unfortunately it wasn't. And all throughout high school, throughout college, I was pretty much addicted to tanning beds, and I would go every day, sometimes, 15, 20 minutes a day. It was really an addiction. If I didn't go one day, I would go longer the next. I contemplated at one point joining a second tanning salon so I could go multiple times a day. I didn't do that, but there were people that did. And it really is kind of an addiction of sorts. And so post-college, I had a friend at my first job out of school, and we somehow started talking about tanning, and we would go with each other on our lunch breaks. And I thought to myself, because she's in her 40s, I've got some time before the damage would set in, and I would justify it in my head, cognitive dissonance at its finest. And I thought nothing would be wrong. And so because I was actually a moderate risk, I am very fair. I have had those blistering sunburns and tanning beds. I did get an annual skin check. So in my late 20s, I had my annual skin check, and the doctor finished up and said everything looked great and she'd see me next year. And I had a little intuition chime up, and something told me to ask her about a little tiny spot behind my right knee. And so she took a second look at it and decided to biopsy it. But I didn't think it would be anything of concern because, she said everything was fine and, kind of missed it initially. And I thought nothing of it. So a few days later, I was about to do my biggest business presentation of my career thus far. At the time, I worked for General Mills, and I was doing a big sales pitch for the Safeway corporate headquarters. So I had just landed in San Francisco, and I had a voicemail pop up, and it was the doctor herself calling. And so since it wasn't the office, my first little alarm bell kind of rang, and she said that the biopsy came back and that I had melanoma. And so from there, I was immediately scheduled for surgery. And the melanoma itself was one of the smaller ones. It probably was just about the size of, or just bigger than the tip of a ballpoint pen. And I had surgery, and for a mole that size, the excision was sizable. So I would say it was about 3 inches long by about an inch down to my tendon behind my right knee. And after the procedure, the surgeon mentioned to me, and this was finally the light bulb that I needed to be sun safe and stop the tanning beds. But because of the proximity of it, it was very close to my lymph node. And if I had waited another year, even, we would maybe be talking another prognosis. So intuition is really what saved me there. And I'm so glad I listened to it to get that reevaluated. But that procedure was done in October of 2010. And from there on, I had skin checks every 6 months for about 10 years. And I am melanoma and basal squamous cell carcinoma free for the last 12 years. And I had subsequently moved my file over to Mayo Clinic, and they put me into a clinical trial of sorts. It was a machine that took 360-degree view photos of your body. And so I did it about 7 years ago, and they're great for, monitoring mole change year on year. And, if it's something that not everybody has access to, even taking your own photos is a really good idea, just to analyze yourself for those skin checks, just so you can kind of see the progression or hopefully lack thereof. But I personally now have a sizable scar behind my right knee. And every time I see it, it makes me think of a few things. Number one, speak up if you have a concern, and always follow your intuition. You know your body. And if you don't think something is right, speak up about it. Two, tanning beds are not a safe alternative for the sun. I think that should be common knowledge, but a lot of people still think otherwise. And always wear sunscreen or stay in the shade. I am personally myself working with the American Cancer Society CAN network to hopefully pass a bill with the Arizona legislature regarding tanning beds, and making them either needing to be, illegal for minors, essentially raising the age limit to 18, or to obtain parental consent. So it hasn't had success just yet to pass, but something that hopefully with the right folks in office, they'll see the importance of that and get that through. So thanks for letting me tell you my story, and I appreciate your time.
Jen, thank you so very much. I hope that everyone on the call was able to lean in and listen in and pay attention to comments, as well as the insight that Jen and Dr. Costello both shared today. Super important information. And thank you both for your time, your insight, and just sharing incredible, very important information with us. Again, if you have any questions about anything, please put those in the Q&A, and staff will field those questions for us following today's event. We want you to look out for an email with a recording of this event, for resources, as well as an evaluation in about a week. So again, thank everyone for joining us today. To our speakers, Dr. Costello, and to Jen, thank you so much for your time and sharing insight and very important information with us. And so we ask everyone to have a great evening and take care. This concludes our Cancer Town Hall for this month. Thank you so much.